Combinations is something that I'm quite excited about. The other thing, which is true for I think all drugs, is patient selection, patient and or tumor selection. So one of the obvious questions that most people have is, well, what about PSMA imaging? So what we do know overall, this is for a bigger data set over more than a decade, is that some patients with negative PSMA scans will still have a response. So an individual patient that's had a lot of different therapies doesn't have a lot less, I wouldn't want to exclude him based on a scan. That being said, when we do look at the data, because we treat all comers, so we have negative scans as well as very bright scans, those that have brighter scans appear to have a higher response rate. So I think that if there's choices between therapy and two are equal, the one with the hotter PSMA scan might respond better to that particular type of therapy. Beyond that, I think there are other aspects that might emerge. So last year, 2019, at AACR, as well as this meeting due ASCO last year, we presented a small subset of data, 20-ish patients due ASCO with whole exome, and 50-ish patients with a number of different targeted sequencing platforms, and some things such as BRCA2 stand out in terms of a better response, PFS, and overall survival with a PSMA-targeted radionuclide therapy, which we predict that radiation, the mechanism of action is damaging DNA, and those with DNA repair defects might respond better.